There we go. So welcome everyone to our May Liverpool Dementia and Aging Research Forum webinar. It's a pleasure to be joined by Sanda today, who is one of our 4 DEMCOM research fellows at our applied research collaboration in the Northwest Coast. And Sanda is specifically interested in his project on exploring dementia prevention, care and support in Muslim and religious communities, and what we can still learn from this. So it's a topic that we haven't discussed in a long time in this forum. So I'm really intrigued to hear about Sanda's work, and then afterwards we will have time for discussing this as well. So Sanda, over to you if you want to start your talk.
Yes, absolutely. Thank you, Clarice, for the introduction. I hope you can all hear me okay. Brilliant. Excellent. Great. So thank you for having me to share this presentation on exploring dementia prevention, care and support in Muslim and religious communities. And sort of highlighting, something that I think we already know and something that we still need, to learn from this topic. Just to start off with a bit of background, about myself. So as Clarita correctly mentioned, I am an NIHR dementia research fellow based in the Northwest Coast. So administratively, I'm based at the University of Liverpool, and my supervisors for the projects that I'm carrying out as part of my fellowship are based at Lancaster University. So my lead supervisor is Professor Carol Holland, and I'm co-supervised by Professor Heather Brown and Dr. Faraz Ahmed. My background in terms of academic discipline is in public health, so usually taking a very population, perspective, and you hear that come across quite profoundly in my conversations today. However, these have direct, implications for individual and clinical care and support when it comes to people, living with dementia. I thought it might be useful just to give a bit of background in terms of the areas that I've been involved in when it comes to research in dementia and also in relation to religion. So I started off my research in dementia from my PhD, where I examined the use of nostalgic memories to improve the health and well-being of people living with dementia and their carers. Afterwards, I went on to explore further how to actually develop a nostalgia intervention, for couples who one of which is living with dementia. For this fellowship, I am focusing on 4 main areas. So one of the areas that I'm currently looking at the relationship between religious practices and the risk of cognitive frailty. Although cognitive frailty is different from dementia, but it's a significant risk factor, to dementia. I'm also analyzing some data to look at how the risk factors of dementia are distributed among religious communities, in England. I've just finished analyzing, that data, and there's some interesting results coming out of that. However, today I'll not be sharing results from my fellowship, so I'll just be stating how that fits into the sort of gaps in the literature that I'll be highlighting later on.
Sanda, sorry, just to briefly interrupt you, the audio is still a little bit blurry, so I don't know how to
do a bit of adjustment here to see how that works. Is it any better?
Hopefully, yes. Let's see.
Do feel free, Clarissa, to interrupt me if it starts messing up again. And apologies for that. It's full connectivity at my end. I would state where I'm living so that you know that I have poor connection in my area. So I'll not state where I am. I am dialing from. But just as I was saying, talking about the local areas of my fellowship, I'm also exploring the views of Black Muslims on the causes of dementia. I've just ethics approval, for this research and just starting to recruit participants to do some qualitative study. I'm also looking at how to extend the concept of dementia recovery colleges within Muslim communities. I'll talk about all the later on in the presentation. So in terms of focus for today, I'm nowhere, declaring that I'm an expert on this topic. In fact, I am a beginner researcher in this particular area. So what I will be presenting today will be my views and perspective based on my synthesis of the literature and my research ideas in this area. So please feel free to share your views and comment in the sort of things that I say. Please feel free to disagree with me, to challenge me. I promise you, I'm not going to take it personal at all. Okay? So, in terms of format of the presentation, I'm going to give a broad overview when we talk about religion in research and in health research. And I also talk about why it is important to consider religion specifically when it comes to dementia research and why the focus on the Muslim community. I believe the rationale that I'll be giving could be extended to other faith communities as well. I'll then highlight some of the gaps in research when it comes to religion and dementia, and some of the efforts that I'm sort of proposing to fill in these gaps. I'm sure by that time I would have bored you with my voice and spoken too much, and perhaps the audio would have been fed up with me by then. So I'll just quickly finish up with a couple of points to conclude the presentation. But before I go into any of these details, I'll just first of all, just like to get your, just your opinions and how familiar you are with, dementia research within religious communities. I think the best would have been to, set up, some sort of poll, on Zoom to do all these things. But I've not been able to do so. But if you can quickly just pop in the chat, I believe the chat is active for all of you. How familiar are you with dementia research, within religious communities? We're just spending about 30 seconds, on this. Yep, great. I can see some stuff already coming in. I can see Mohammed Raouf is here. So Mohammed, I believe I have got some of your work in this presentation as well. So Mohammed, please let me know if I'm misconstruing your thoughts and your arguments. Yeah. Great. So not very familiar, somewhat familiar, good, not very good, great. Fantastic. So I think we have a whole range of experiences here when it comes to your familiarity with dementia research and religion. So it's a good place to be. So hopefully there is something that some of you can take out of this presentation, and there are things that some of you could also contribute to it as well. So thank you for all those points, opinions on the poll. I just want to share this quote with you from Martin Luther. So Martin Luther is a German priest, theologian. He's a hymn writer and also a professor. And an Augustinian friar. He's actually regarded as one of the most influential figures when it comes to Western and Christian history. And I like this quote of his because it's got a lot of implications when it comes to research on religion and health. So he says that religion that gives nothing, costs nothing, and suffers nothing is worth nothing. So this is a very emotionally and politically charged quote. But to me, the sort of message that I get from it is that religion is not just a symbolic concept. Okay, it's got a huge influence on individuals in society. It's also got consequences as well in terms of its impact. Not every time very positive, sometimes could be negative. But another interesting message that I get from this quote is that the actions of individuals in society, in the community, has also got an impact on religion. So They're just suffering of nothing. Okay? So this is a, to me, it's a good motivational book to sort of study the relationship between religion and health. But let's continue with a very generic definition of what religion is. And a lot of the literature agree to this definition. So it is that concept that involves a set of beliefs and practices which brings people together in the form of a community. And that community usually have a shared vision of some sort of belief or union or experience with the divine or transcendent. Now, two main concepts here that are particularly important when it comes to religion and research. That idea of that sense of community brings in itself unique characteristic over here that has strong influence on health. And when we talk about the experience of the divine or transcendent, in research pertaining to religion, we're not very much concerned about the theological, and religious debate that sort of form this, but we're more interested in how these sort of experiences actually influences people's health and well-being. But two other related concepts that you will find when you start talking about religion and health is this idea of spirituality and secular humanism. So quite related to religion, but a bit distinct. So spirituality also usually involves experiences with the divine or the transcendent, but it's not usually experienced in the form of a community. It's usually experienced at an individual level. Whereas the concept, secular humanism, involves understanding human experience, usually through rationality, and science, and does not involve the transcendent. I mean, quite a popular framework.
And sorry, could you maybe try and use a headset if possible? It's still quite unclear at times.
I will try that and see.
Might be working better.
Let's get out the tools. Is it any better?
Well, sounds already a little better, so let's hope. Sorry for disturbing.
Completely. Better, Clarita.
I think so, yeah.
Right. Okay, let's see. So this is quite a very popular framework that sort of conceptualizes the sort of things that we look out for when we are investigating the role that religion, plays in terms of health. And Huang and colleagues have written quite a lot regarding this. So you can see that from the left-hand side, the intersectionality that religion sort of has with spirituality. Not a huge intersection, but quite distinct as well. But religion is usually very distinct from secular humanism. And it tends to provide certain resources which could be positive or negative, including establishing meaning and purpose in life, well-being, peace, hope, connectedness, but also has some negative connotations, such as depression, addiction, and all that. And these sort of translate to health. Now, this is a very broad, framework. Okay, so you can actually argue and debate those causal mechanisms between some of these factors. But what I am really interested in, very much interested in, is actually how that relates to dementia. Okay, so in the broader model, dementia is not included, but I'm very much interested in how this relates to that. Okay, so when it comes to exploring religion as a concept in research, there are various characteristics that are usually, examined. One of them is religious affiliation. Now, this is what a lot of people tend to think about when we are investigating the concept of, religion in research. So, the sort of religion people ascribe to, or the faith community they adhere to. But that in itself is usually not sufficient to explain the way religion influences health, because people can to a particular religious faith, but they may not actually practice, that faith. So we tend to look at, practices within various religious faiths as well, things such as, religious, attendance, how to people, sort of motivations for people to practice various religious norms and these the sort of connection or attachments that people tend to perceive to have with the transcendent when they are practicing a particular faith, how people usually use religion to cope with adverse health, events. Usually, those health events that is sort of threaten their existence. And now this is the area where dementia research has been examined quite widely, how people use religion to cope with the existential threat of with dementia. So there is also the concept of how religion can be used to support people to improve their health and well-being. And that is usually to sort of integrate them within the wider, so between what religion can advocate and influence and what is available within the wider community. So I'll now move to the second aspect of my presentation that will look at what is important to consider in dementia research. Now I think one of the reasons is because dementia, as we all know, is a wicked problem. So the term wicked problem is a popular term in public health research, usually used to describe very notorious problems or health conditions. And I'll sort of tell you in a minute the way that relates to dementia. I just wanted to highlight some key studies and articles that I found quite interesting, that sort of explicitly talk about dementia as a wicked problem. So I'm not going to describe what these studies are talking about, but I'm just sharing some studies that I find interesting in this area. But to sum it all up, I mean, these are things that I believe you all know with regards to dementia. It's a very complex, a very multifactorial issue. Biological possibilities are still not sufficient to explain prognosis and the trajectory of the health condition. I mean, the societal and economic impacts of dementia, quite huge, very concerning, and loads of ethical and political issues when it comes to decision making and resource allocation, in dementia care and support. I mean, all these things, I believe you're all familiar with that. Challenges that dementia poses to the healthcare, system, the idea of stigma, and false perception of what dementia is and how to manage it. Progressive and long nature of it, and kind of huge research gaps when we're still thinking about cure and how to manage symptoms and signs of dementia. Now, I'm just highlighting this, explaining how dementia is a wicked problem to support the argument that is the reason why we actually need to tackle it from every possible angle that we can. Okay, especially those things that go beyond the individual level. And this is where religion comes in as a key concept to consider, when we are thinking about care, support, and prevention of dementia. Another reason also is that religion, is perceived as a social determinant, of health. It's a powerful driving factor, that influences, the way people are exposed to certain, health conditions within our society, and actually also, seek care and support, on services within our community as well. I think this is highlighted a lot, among other things that were highlighted, during the pandemic, where we saw the role that religion could actually play, in managing, that. So it's a significant social determinant, of health. Now, quickly jumping on to, so why the focus on the Muslim community? And as I said earlier, some of the reasons that I will be presenting, you realize that can be extended to other faith communities as well. So, I mean, first of all, this might be interesting, for some people, but dementia is not an alien term when you start looking at the theologian scriptures of the Islamic, faith. So this is an extract of a chapter and a verse in the Quran, which is the holy book, of the Muslims, that sort of has implications of dementia. And a lot of several Muslim scholars have written quite a lot on these kind of verses, showing that indeed the message being portrayed over here is dementia. So in Quran chapter 16 verse 71, it states that, and Allah, which is the Arabic term for God, and God creates you, and then He causes you to die, and there are some among you who are driven to the worst state of life, with the result that they know nothing after having had knowledge. Okay, surely God is all-knowing, powerful. Now, this sort of depicts, memory loss, pertaining, to dementia. But there are quite strong messages in there, as well. I said that a lot of Islamic scholars have written about. This usually portrays that dementia is not victim blaming. It's not a fault of an individual, but actually something that usually occurs beyond the control of the individual. And that has implications on the way we perceive dementia in the first place, and how we actually offer care and support to people who are living with dementia. But what is interesting is how the wider Islamic faith sort of perceives dementia. And now I'll share some sort of research that has actually shown that there are quite wrong perceptions among the Muslim faith when it comes to dementia, which usually has got no grounding in the way it's even portrayed in the holy books. So that's quite interesting to see how, as researchers interested in this area, how we can actually work with faith-based leaders to sort of change that perception among the Muslim community about dementia. And as I said, I know Mohammed is in the room over here, and I did say that I was going to share some of his work. So Sufyan Abid Dogra, who's the lead author of the book British Muslims, Ethnicity and Health Disparities, where Mohammed has written a chapter specifically focusing on dementia among Muslim communities in the UK. So very, very interesting in terms of some of the key issues being, highlighted, over here, where, it's very, shown that dementia is often, misunderstood within the Muslim communities, with a lot of, spiritual connotations attributed, to it. There is that misconception that it's a normal part of aging, and that usually deters people from seeking those care and support services within the community. There is also that issue of service providers not being aware of providing culturally appropriate services for the Muslim community. And this last point, is quite significant, that, culturally, there's a lot of expectations placed on women, to provide caring roles for people with dementia, without seeking, external, assistance. Again, just to highlight why it is important to focus on the Muslim community. So some epidemiological statistics here from the Pew Research Center, which does a lot of research when it comes to religion globally. And I sort of projected that globally the Muslim population is estimated to actually become the fastest growing religion, and to grow by 70% by 2050. Okay. When we come to England and Wales, the picture is not too different. So from the recent 2021 census, it's been shown that Islam is the largest minority religion in England and Wales after Christianity. So even though the proportion of people who are actually declaring that they do not practice any religion has sort of increased in England and Wales. There's also been an increase in the Muslim population. But for the very first time, the proportion of people who perceive themselves to be Christians in England and Wales have actually gone below 50%. But Christian religion is still the majority, in England and Wales. Okay, so to kind of like my last aspect before I conclude, sort of looking at some of the gaps, in research on religion and dementia, and some of the my ideas that I'm proposing to fill some of these gaps in this area. So to sort of sum up some of these, most of the research currently being conducted when it comes to religion and dementia has focused primarily on how religion influences the care and support for people living with dementia. So how people use religion as a resource to cope with the existential threat of living with dementia. But even in these research, researchers tend to take a very generic perspective on religion. They tend to lump all religions into one. But there are arguments that there are nuances in terms of how specific religious faith might actually be impacting on the care and support, for people with dementia. But this is rarely usually examined in research. When it comes to the prevention side of things, quite very limited studies that have sort of looked at the role that we could actually play in preventing or reducing the risk of dementia. There are a few research that has been done in this area, but mostly from cross-sectional studies. So, the study that I have highlighted over here, it's an ecological study that looked at how various religious practices affect dementia burden across various countries, and quite showing some positive results in terms of religious practices reducing the burden of dementia. But this is very cross-sectional, with a lot of limitations. So longitudinal studies are usually lacking in this area. Where there are some, the outcome usually being examined is cognitive impairment as a proxy for dementia. But we do know that, people can have mild cognitive impairment and not necessarily have, dementia. Again, there is lack of understanding between how specific religious practices, actually influence dementia risk, which is very important. If you want to start thinking about how religion can reduce the burden of dementia and terms of risks, then we need to understand which specific religious practices, influence the risk of dementia. And again, lack of understanding of the causes of dementia amongst specific religious, communities. And at the moment, to my best of knowledge, there's no randomized control trial that has sort of examined the effects of, religious activities on dementia risk, or actually even improving the health and well-being of people living with dementia. Still, dementia prevention, just to highlight a bit more, what we know about current dementia prevention strategies, implications they have on religious communities. So anybody who is interested in the area of dementia prevention, you'll be familiar with this figure over here and this research by Winston, and colleagues. That's sort of highlighted, globally, the key contributing risk factors to dementia risk, or the causes of dementia. So what you see here, these percentages in epidemiological terms are what we call the percentage attributable fraction, which means if we get rid of this cause, by what, to what extent will we reduce the risk of dementia? And, it sort of highlighted things such as hearing loss, being kind of a very significant risk factor. If we can actually control for hearing loss, reduce, prevent it, then we can reduce the risk of dementia by 8%, followed by less education in early life, and then, smoking in later life. Okay, so we do know there are common risk factors here when it comes to dementia, but, will these be similar when we start looking at specific populations such as religious communities? And we see from other research that possibly there could be some sort of, differences So this recent study, conducted in New Zealand, that has looked at the same distribution of these risk factors among ethnic groups within New Zealand, has actually found that the distribution of these risk factors, differ when you start looking at specific ethnic, groups. So I don't know whether you can see the figures here. You realize that for some ethnic groups, such as the Maori, most significant risk factor is obesity, and for the Pacific people as well. For the Asian, I think it is I think it's still do with hearing loss, and for the European population, I think it was social isolation. Okay, so it's thinking about how these inform preventative strategies and how can we extend these to religious populations. So as part of my fellowship project, one of the things that I am doing is sort of, trying to replicate these analysis to see how these, risk factors are distributed among religious and non-religious communities. And I'm analyzing the ELSA data, set to sort of, explore that. And some interesting results are already coming out of that. Just to, again, talk about gaps in research, usually when we talk about inequalities in dementia research around prevention, care, and support, there's, huge focus on ethnicity, okay? But, I argue that religion actually brings people together in kind of like unique ways that ethnicity, does not. So, for example, I'm a Black Muslim. My lifestyle practices are more likely to be similar to someone who is a Pakistani in the UK, okay? Because religion will shape my lifestyle similar to that person in terms of maybe nutrition, in terms of activities that I do daily, places that I go, the way I seek social support. It might differ, okay? But if you were to use ethnicity to categorize us, you categorize, another Pakistani male different from me, but group and lifestyle practices are likely to be very different from another Black man who is a Christian. Okay. But more interestingly, it's usually difficult to separate ethnicity from religion. And I think that's that's it with a lot of social characteristics as well. They're all not one individual social characteristic. So there's nothing like, you're not fully a Black man or a white, a woman. You are made up of an intersection of a lot of social characteristics. You can be a black Muslim in a high deprived area, blah, 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 blah. So at any point in time, we're made up of so many intersections of social characteristics. And I argue that, the concept of ethnicity and religion could actually be very important and interesting to explore when it comes to, inequalities in dementia care and support. And this report that was published a couple of years ago by the Muslim Council of Britain, sort of collating essays from Black Muslims specifically, because the arguments were that Black Muslims are likely to face unique issues and problems compared to the general Muslim population in Britain. And it sort of highlights some unique issues over here, which I've kind of like highlighted on this slide, sort of showing that, Black Muslims are actually at higher risk of certain chronic health conditions such as hypertension, diabetes, and obesity. It highlighted, unique, adverse experiences of Black women when it comes to accessing maternity services, and shows how the pandemic has actually not made any of these better, but actually worse. Now, based on these ideas, I think, one of the things I'm trying to do for my fellowship project is to then understand how Black Muslims in particular view dementia, and how they also view the causes of dementia as well, because my argument is that could be quite unique and different from the way the general Muslim population, might perceive this. Coming towards the end now, one of the things that I've also been passionate about is the way that religious centers can be used as health promotion centers to enhance dementia care support and also change perspectives of dementia and also avenues to sort of help to increase, diagnosis of dementia, early diagnosis, because early diagnosis, as we all know, translates into better care. And quite recently, Joe Stafford at Manchester University and some colleagues have conducted a research lasting for about 18 months, exploring the use of faith-based centers to improve the well-being of older people. And they actually found that there's a lot of potential to use these centers to improve healthy aging in the community, and particularly around issues to do with social isolation. Based on these ideas, and recently we were awarded some seed money by the Alzheimer's Society to sort of look at how we can extend the concept of dementia recovery colleges to Muslim communities. So dementia recovery colleges are, these are currently based in mental health services where people who are diagnosed with dementia can go there and they're enrolled in a course, just like you go to a school. But these courses are specifically, tailored for the person living with dementia and their carers, and it could be around outcomes that are more important to them, be it improving their well-being, reducing social isolation and all that. Nothing specifically to deal with dementia, but to deal with the overall well-being and quality of life. But because they are currently based in mental health services, there is still the issue of stigmatization and also the idea that there are inequalities in access to these services. So the idea is to develop a model that will move these dementia recovery colleges from mental health services into the community, into faith-based centers, where mental health practitioners will work closely with faith leaders to sort of deliver these college curriculum to people living with dementia and their carers. So I have spoken too much, as I promised that I will do, and I have done so rightly. So to just sort of conclude, I hope I've been able to carry the message across that there is a huge potential role that religion can play when it comes to prevention, care, and support in dementia. But currently, there are still loopholes and gaps in the evidence to do that. And I think what will be more important is to start looking at research among specific religious communities. Thank you all for listening, and I believe Clarissa is probably now time for any questions and comments. And apologies for the audio.
Yes, thank you very much, Sander. Lots of work that's going on, which is fantastic, and well done on securing some additional small funding as well to continue your work. So we're now taking some questions from you. If you want to ask anything or discuss anything, you can put your questions in the chat. And Annie has already kick-started us off. Annie is intrigued by the use of the word wicked. Do you want to elaborate on that a little, Sander?
Yeah, so I totally agree, Annie. So wicked is actually, you could call it a jargon, usually used in public health, to refer to problems in which there is no single solution to them. Okay, they are multifaceted. They are kind of like interdisciplinary, where you can look at it from several perspectives. There's no one solution. The root causes are still not well understood. And this is just a general term we use to describe, issues like that in public health. So similar issues are things such as obesity, smoking, alcohol, for example. These we term as wicked problems, and dementia can be rightly classified as so. The causes are multifaceted. We still don't understand the full biological plausibility of its prognosis and trajectory. We're still trying to understand some of the causes of this and better ways to manage it. So there's no single solution to it. And I mentioned that to argue that is why it might be useful to think about exploring concepts such as religion, which you normally wouldn't just think of when you are sort of thinking about ways to prevent dementia, for example. So that's what the term wicked problem actually means.
Great, thank you. So we've got another question from Marija. looking specifically at the religious practices and how they may affect risk factors. So you've had the nice slide of Livingston et al. Of the modifiable risk factors there on a few slides earlier. And Marija is asking whether you will be looking at how religious practices might influence those risk factors for dementia in your research.
Very, very, very good thoughts, Mari. So yes, that's one of the ideas that I have to explore, later on. So one of the pieces of research I'm currently doing at the moment is looking at, which sorts of risk factors contribute more to the risk of developing dementia. And I'm considering things such as social isolation as one of them. Those modifiable risk factors from the Livingston et al. Study. So in future, it's actually, yes, then to see whether there are specific religious practices that influence these risk factors. So, for example, is it frequency of church attendance or mosque attendance that has, a greater effect on risk factors such as social isolation or hearing loss or obesity or hypertension. So yes, this is, in terms of moving forward, these are some of the things that I think, I can explore when it comes to religious practices and their influence on these risk factors.
Then we have another really interesting question, which I love because I'm a non-native English, and I love the fact that translation, or not love the fact, but I'm intrigued by it, that translations can sometimes be wrong, and we have to be really, really careful of the meaning and interpretation of a word in a different language. So often for me, if I would directly translate something from German into English, that does not make sense. So Mohammed points this out really nicely here, that in the Quranic verse, apologies for my pronunciation. So you translated it as worst of ages, and Mohammed uses translation that refers to it as feeble age. So differentiation between worst and feeble. What are your thoughts on that, Sander?
Absolutely, I totally concur with what Mohammed is saying, and I think that is where the opportunities arises to work with faith-based organizations to sort of explain and sort of clarify some of these myths around the way people sort of understand how some of these spiritual scriptures portray dementia. So absolutely. Right. If you look at, the Arabic language is a very complicated language and usually don't have very direct translation of some of its words, into English and other languages. And therefore, yes, a lot of care needs to be taken, into consideration when it comes to that translation. And yes, absolutely, the word was, as Mohammed has pointed out, for some refer to feeble because there's actually a direct translation to describe what is even about that memory loss aspect to just one word English. And that's why the word dementia is not very clear when people are even translating what is written in Arabic in that particular verse. And I think it creates an opportunity here to sort of work with faith leaders about, how these can actually be clarified and used to change perceptions about, faith communities on dementia. Because the word worse, I have heard people translate this in the Quran to actually mean, that means it's the fault of people who have dementia because they've been in, and it's like there's nothing that can be done about it. It's hopeless because it's that thing, everything else is better than that. But that's not actually the meaning of that. Some Islamic scholars have explained it as actually, it was just a caution to just show how we need to pay particular attention to this and look at juxtaposition of other messages that come before this verse. And there are ideas of how things such as improving social connections, taking care of older people within the community could actually feed into how we care and support people with dementia. So totally agree, Mohammed, in terms of how these scriptures can be misconstrued. And I think that may actually be the basis for some of the misconceptions that we have within the Muslim community about what dementia is and how to care and manage it.
Okay, thank you. And just a comment from James. Interesting as well that so he works on joint dementia research. For those of you who don't know, this is a fantastic platform where people living with dementia, carers, and people who don't have dementia, such as myself, can register if they wish to take part in dementia research. And he's highlighting that religious belief is not a demographic that is captured on there, just ethnicity. Sander, would you think that it might be important or maybe too much information if people were able to tick this demographic?
I mean, absolutely. And first of all, just to say, James, I'd like to use this platform to thank Dementia, Joint Dementia Research again, because I actually recruited my participant for my PhD through the Joint Dementia, research platform. Yes, I mean, this is what I am advocating for. I think when it comes to demographic characteristics, we usually capture only ethnicity. And as I said, religion is usually seen as a sacrilegious variable. People don't see it as a social characteristic that bring people together in unique ways, and that's a big issue. And wherever I go giving talks around this, I advocate for religious affiliation and practices to be captured as part of demographic information. It's great to see that data sets such as the English Longitudinal Study of Aging data set has captured information on religious affiliation and practices, but they did that only, at wave 5. And they never did that again until wave 9. And I just looked at the wave 10 of the ELSA again, and they didn't capture it anymore. So I think having the variable will be important. And I was also very impressed the way the recent census has captured a bit more detail when it comes to religious affiliation, although it doesn't go into detail when it comes to practices. So yes, James, I agree with you. I think it's something that we should be capturing, as part of demographic information, because it's a significant social determinant of health.
Great, fantastic. Thank you so much. Thank you for all the questions. I think that's been pretty much all of the questions, I think, all the major questions. But thank you, everyone. Sander will soon be publishing, he's told me before this webinar. So if you fancy reading more about his work, then do follow Sander and his work. But thank you. So first of all, I love doing this online. So let's react and give him a good clap because we're not in person. So thank you very much, Sander, for your webinar. The next webinar is just being finalized, but it will take place on the 24th of July with Associate Professor Miguel Padeiro from the University of Coimbra in Portugal, who will be talking about the state of dementia diagnosis and care in Portugal. Very interesting because it's way behind the UK, and also a specific work on geographical inequalities in dementia diagnosis and care in Portugal. So stay tuned on this, and also I've shared in the chat that we're having our annual conference on the 23rd of October. So anyone who would like to join, please register. But thank you again, Sander. I'll stop recording now, and hopefully we will see you soon at more events.
Thank you so much, Clarissa, for having me. And thank you everyone for coming.